Hello, everybody. Thank you for asking me. I'm the Professor of Liaison Psychiatry in Leeds, and I've had a long-term standing interest in this problem. By long-term conditions here, I mean long-term physical conditions and medically unexplained symptoms. And when I'm talking about severe complex cases, I'm talking about, I suppose I'm at the other end of the park from Mike here, where we're talking about not terribly common. So suppose you've got a fairly substantial general practice with about 6,000 people on the list with 4 or 5 partners, and just under 5,000 of those are adults, and 1% of them are in this group that I want you to be thinking about. Really severe, difficult people only constitute 1%. That's 50 people. And you multiply that by the number of practices in a city like Leeds or Bradford or Wakefield. One of the challenges that thinking about what to do about, because I'm here to say I don't think we've got the service model sorted out for this problem. Scaling up is undoubtedly one of the problems, because you multiply 50 by the number of practices there are, and by the available expertise, you've got a big problem there. I think maintenance is a big problem. Relapse is very, very high in this area, and knowing what to do about chronicity. And I think coordination of services is a big problem. And I'm here to tell you, Brendan, that psychiatrists do quite a lot more than prescribe drugs, even if you don't think so. One of the things I want to say then about... actually, I'm not going to talk about evidence very much. I'm going to talk about how I think about formulating this problem in a way that might move us towards thinking about what services could look like. So I haven't got a solution. It's a sort of opening up the discussion here. And the first thing then, how I want to look at this then is to say, although in one way, if you thought about it, if you look at the 2 ends of the spectrum here, people with a long-term physical illness that they're struggling with, for example, somebody with COPD who's depressed, or somebody with type 1 diabetes who's not managing their insulin and diet very well, seem quite different from somebody at the other end here who's got a chronic medically unexplained condition, chronic unexplained pain, chronic fatigue, fibromyalgia, one of these states where, as far as we know, there is no disease process underlying the illness that they have. In fact, I think when you start thinking about these severe complex cases, they have quite a lot in common. So the commonality is what I want to talk about. I think diagnosis is not a very useful way of pursuing thinking what that is and what services ought to look like. So that's what I'm going to... So I'm going to really talk about 3 things. First of all, this idea of if we move away from diagnosis and start thinking what constitutes the problem of severity and complexity in chronic illness of this sort, that's the first thing. Well, second thing, I'll put the 2 together. And then I'm going to run this idea of 3 possible models of care using what's the word I want? An architectural metaphor of some sort. So, I'm sorry, lots of the slides have been quite small writing, so I'll just tell you what this is, and it's the only one that's got small writing on it. Where we often, so I'm starting with this. Okay, let's look at chronic long-term physical conditions. The standard sort of traditional way, recently conventional way of thinking about people who've got psychological or mental health problems in this space is to think that they've got some sort of associated distress or mood disorder. It's how IAPT works, for example, as they move into this long-term conditions. So, they say what we've got to do is screen people, give them a PHQ, give them a GAD. So the people who've got lots of symptoms in that, they're the people that we're interested in. Yeah. There are 4 columns here. This is headed affective and means emotional, so it's got emotion words like depression and anxiety and irritability. This is headed behavioural, tearfulness, crying is a sort of behaviour if you're in that frame of mind. Help-seeking. It's quite old-fashioned, this, so it uses words like non-compliance that we're not allowed to use anymore. Ways of thinking, cognitions, that's just ways of thinking, and somatic or physical symptoms. So that's the whole of distress. It's got 4 components to it, because the 5th ring in the 5-ring circus that Mike was talking about was the social context within which this stuff arises. So this is...
Why is euphoria a form of distress? bottom there?
Because it's sorry, it should have said morbid dysphoria, abnormal dysphoria, euphoria. There's a state in which feeling elated is not a normal state.
Hypomania.
That's a diagnostic label for a particular... And actually quite a lot of people who are hypomanic aren't euphoric at all, they're irritable, which is... but something in that area of... So the standard way we're taught to read this distress table is, because this is how English is written, is to read it in rows, right to left. So we say there's a depressive state here characterized by certain emotions that we call depression or miserableness or low mood. GPs are very adept at thinking of lots of words for this, so they don't have to... well, they were when they were trying to avoid quaffing everybody with... there's something like 120 read codes for being miserable. Crying, certain sorts of thoughts, and this has been a big development in brief therapies in the last couple of decades. The idea that how you think is an important part of your mood state rather than just how you feel, and certain physical symptoms. So that's a depressive disorder, or we could think of an anxiety disorder that we read in just the same way. One of the things that that I have been interested in the past is you can keep going down this list, and for example, I think one of the things that's a bit under thought about is the idea of the irritable mood state. If you want to lecture about it, sometime my wife will come along and help you out. Now, I want to suggest to you that there might be a different interesting way of reading a table like this, and that's reading the columns rather than the rows, and start here with the idea of somatic distress. It's barely written in. If you say distress, people think of something emotional, usually, but actually you could think of somatic distress. So if you see somebody with a lot of physical symptoms, they're in a state of some sort of distress. It hangs out quite strongly with emotional symptoms of distress. I don't know if you can, because this is greyed out a bit, but this is a study that was published, it's 20 years nearly now. They did a great international study where they asked people in a number of cities around the world how many symptoms of emotional symptoms they'd got. That's in the first column of the table that I showed you, and how many physical symptoms they'd got in the last column of the table. And they're extremely strongly related all over the world. The happiest place in the world seems to be Nagasaki, either that or the stereotypical view of Japan as being saturated with social desirability responses is they won't tell you how they feel. And the most miserable place in the world is Santiago. Manchester's pretty miserable, you'll be pleased to hear. And Leeds will be up here with Santiago. They just didn't come to Leeds to ask them. So somatic distress. The second column you could read is the cognition column. I've just highlighted one there, the idea of thinking that there is nothing you can do about a particular state of affairs. Helplessness is, if you like, a cognitive position. And quite a lot of the cognitive therapists have concentrated very much on the negative cognitions, hopelessness, sense of personal thinking negatively about the future. That's the hopelessness, thinking negatively about yourself. Is the idea of personal worthlessness. And I haven't put up thinking negatively about the past there, which was the origins of Beck's famous cognitive triad. One of the things that I think is really interesting, and it crops up a lot in this area, is people who don't have positive thoughts about things, which isn't the same as having negative thoughts about things. And it goes with a sort of mood state that I think characterises people, particularly with medically unexplained symptoms of a certain sort, and that's what I'd call something like joylessness. They're not all manifestly miserable, but there don't seem to be any pleasure in life and no positive thoughts about it. Ikigai is a Japanese word that means sense of purpose in your life. So we've got somatic distress and cognitive distress. Where this table lets me down a bit is characterising the behavioural side of this, because the words are drawn from a rather conventional way of thinking about mental health problems, and they don't quite capture what we're interested in here. But this sort of social withdrawal, not doing things, participation is a word that's very widely used now. So failure of participation. If we changed reassurance seeking to help seeking, and frequency of help seeking, then you get the idea there. So if we put all these together and say, instead of reading a row and saying there's a depressed state and anxious state, if we put them like this, doesn't that start looking like a description of people who keep coming to their GP with medically unexplained symptoms? And that's what I mean by saying maybe if we think about the overlap between these states instead of in diagnostic categories, it can help us a bit. So if we do that, I think, I'm just floating these ideas, so don't beat me up in the car park, but I think you could think of these as simply being differentiated. In this middle ground, I'm not saying there aren't, in my job, of course, you see people, young people with type 1 diabetes who are in and out with ketoacidosis because they're endlessly not doing the right thing. And they're different from people with chronic unexplained pain. But I'm talking about this big mass of people in the middle who aren't at the two ends of the spectrum. And I think the difference between them is to some extent a difference of balance. When you look at the type of distress they've got, emotional distress in people living with long-term physical illness and not doing so well, it's the sorts of depression and anxiety that Mike's talking about, but with the volume turned up for the more severe complex cases, the medically unexplained symptoms, it's less obvious when you see people that it's straightforward distress. Their somatic symptoms, tradition, if you see somebody with a chronic physical condition and this mood disturbance, you can typically understand their symptoms. Somebody with medically unexplained symptoms, almost by definition, their physical symptoms are more diffuse, less easily understandable and attributable, and so on. Distress-driven help-seeking versus this sort of not very clearly articulated. I think you get the sense when you see people that they don't know quite why they keep coming up, keep wanting more. And then rather different ways of thinking about that have rather different ways of thinking about themselves and what's going on. So what constitutes the meaning that people give to these states is another thing that maybe distinguishes between them. The psychological meaning, I think, sorry to use a word like psychological when I'm a psychiatrist, but there we are. Illness for most people means something like loss. It means loss of physical function, loss of social and personal function, and a really, really important idea that doesn't always feature enough is loss of a cherished idea, loss of something about who you are or what you might have done with your life before you had this illness. There's a threat in a lot of illnesses because in the background you don't know that they're sorted out. They could come back and do other things to you. And there's this idea of restriction, I think, that's really important. It's a very old idea that somehow it limits what limits you. If you think of the medically unexplained symptom world, in my head, a very central component of this is understanding what's going on when the help-seeking isn't working. I think a big part of what the problem is and the way of thinking about it needs to think what's going on with help-seeking. And when you go for help-seeking, you're playing in this territory of putting yourself in a position where I've had a lot of healthcare in the last decade or so, and I don't like being dependent on other people, particularly other doctors and nurses, but you can't get healthcare without being dependent. So in some ways with severe illness, on somebody else's judgment, on somebody else's prescribing decisions, on somebody else's referral decisions, so that raises that element big time, and that raises a negotiation about power and control. And when I've spoken to people about, for example, the issue of prescribing opioids for people with non-malignant pain, this whole business of power and control and who's got the right to say what about what you take for your pain is right there on the. So that's a question of balance there. So here's my definition of what constitutes complexity and severity that isn't diagnosis. You can say it's something about symptoms, number, intensity, duration. I'd include here thoughts of suicide. There's something about help seeking and the frequency with which you turn up, the number of drugs you take, the number of systems of disorder that you have symptoms in. There's something about social function. And there's something about this thoughts and beliefs, and particularly thoughts and beliefs about care providers and doctors that constitute the difficulty of managing it. So that's part one. Does that make sense? I'm quite happy to stop for a minute now and just see if that makes some sense, because we're going to get in now to talking about what services would look like, and if you're not quite sure what it is I'm talking about, it's going to be a bit obscure. Okay? No. So here are my three metaphors for services. The pathway may look a bit like a garden path, but it's actually leading into a deep, dark forest. The pyramid and the network. So one of the things I'm here to tell you is that I think the care pathway is an extremely unhelpful. I think it's an unhelpful idea for lots of chronic disease, but I think particularly in this field it's not a very helpful idea, and I'll tell you why. So this might be a standard care pathway idea for people with medically unexplained symptoms. The GP sees them, they do an appropriate amount of investigation and decide that there's no disease that they want to investigate further, either in themselves or by referral, that the person has got a medically unexplained condition. They try and manage it themselves, and they might then wish to refer on for a brief psychological intervention. It might be a low-intensity IAPT, it might be at a CMHT, it might be and then if that doesn't work, then you step up a gear. There's a high-intensity intervention, a more conventional psychological therapy of some sort, typically for the more severe cases integrated with physical management as well, getting people mobile and concentrating on function, and then you get into a maintenance phase or relapse prevention phase of some sort. The trouble is it's fantasy because of the stuff on the right here that's normally left out of it. So you refer from primary care to a low-intensity intervention. 40% of people don't go, or they drop out after a session because it's not for them, or they don't do well, so you go back to a step and you do the same again, refer people onto a clinical psychology service or a liaison psychiatry service. Another 40% of people say no or won't go or drop out very quickly. I used to see people who had really only come along to prove to their referring doctor that they'd come along. But they were there to prove that you were the wrong person for the problem. I'm talking about the severe complex cases. I'm not talking about the many, many people who are happy to have had something psychological introduced to them. And they drop out, and quite a lot, I'm sorry, ashamed to say, not everybody gets better. So you need a damage limitation. Sounds a bit of an unpleasant way to talk about it, but it's limiting the damage to people as well, managing so they don't get lots of invasive and unpleasant investigation. My wife has worked, as I've already told you what the fan of me my wife is, and she worked for years in South Leeds in general practice. And one of the things she used to say is, when you've all been finished being clever, and you've done all the things you're going to do in hospital practice, these people always end up back in the GP surgery. And that's these right-hand loops, they always end up back in the GP surgery. And when you do that, you're not looking at a linear pathway. So care pathways. There's one other type, I think.
And also we'll go through each specialty.
Yes. So if I drew all the arrows on this about where people were at, you'd end up with this extraordinary cat's cradle of bits of pathway joining up and looping back, but always channeling my wife back with the GP. My pyramid metaphor, I was hoping we could start a bit of a punch-up this morning, so I'll see Brendan outside about what he thinks psychiatrists do. My pyramid pathway says something about this pyramid. This is only a bit like the path. Sorry, my pyramid model is only a bit like the pathway, because what it is. So this is the old stepped care way of thinking about things. So what it says is this slightly unsteady-looking gold person is hobbling, is going up a stepped care thing. You can see they've got the maintenance bit of this sorted out well. And broadly, crudely speaking, in most places, I think the idea goes something like this in terms of the numbers of people seen and the severity of what's going on. You start in primary care, of course. You refer on, and the model is going to be, it's only just really getting going, I think, that the next thing you're supposed to do is ask IAPTs to help out with a few sessions for the people who are distressed. If they don't work and it steps up, then you get into something either high-intensity IAPT or somewhere else, clinical psychology. And why I put liaison psychiatry at the top there, apart from the fact that I'm a liaison psychiatrist, so obviously at the top of the pyramid, is if complexity includes things like attendance in the emergency department, being an inpatient on an acute ward in an acute hospital that hoovers up money, being on multiple drugs where the mental health, multiple drugs for physical symptoms, where the mental health condition, the intervention needs to do something about that, and the risk of suicide, then that feels to me like psychiatry territory, and it's what I did a lot in my day job. Now, I've got three things to say about what goes on in primary care. And what I think GPs have to do because nobody else can do, and then a quick suggestion about what we need to be thinking about in commissioning mental health services. So what I've got here is one aspect of one of these presentations, and it's the patient presenting with chronic pain to get a decision about analgesia prescription. So here's the patient, here's the GP, bottom, of course, the patient up there. And what I'm saying is, in that transaction, there are several bits there are dynamics at play. One is the perception of who's in control of this decision. Is it GP-centred or patient-centred? Another is a sense of continuity in the relationship. I was talking to one of the GPs in our institute the other day. He said, I prescribed this drug for somebody. I knew it was a high-risk thing to do. The next time he saw her, she'd seen 3 other partners in the practice, and she was on 2 more drugs. And it's that sort of sense of who knows enough about you. That plays a lot. That's what we've called a sense of trust and mutuality. We're both trying to work this out together. And clarity of strategy. I do think, particularly as the numbers have got so insufferable in general practice, not insufferable, well, partly insufferable, intolerable, unmanageable, that the idea of a strategic approach to individual complex severe cases is very difficult to maintain in face of the sort of whitewater rafting. What you're doing is calling it on each consultation. And you can't manage these cases on a consultation by consultation basis. So these things are all going on. You've got to keep all those in your mind. And then there are other things going on as well, because that patient may be there for medication, but they may be there for diagnosis. They may say they don't care about diagnosis or medication, they just want a better quality of life. And they bring a whole lot of other things to the party. The degree to which they've got emotional distress, the way they think about things, and their social and other circumstances. Now, this is a GP in a 10-minute consultation about one decision, prescribing opioids to somebody with chronic pain. It's not, and just gives some idea of why you can't expect for these severe complex cases, this is going to be GP managed with as much as you like. But it does point out, it makes me think there's 2 or 3 things where the GP really does have to do. And one of them is, because the GP's doing the prescribing and the stopping the prescribing, they have to have a way of thinking about prescribing to people in this about. And I can't see a way around that being than at practice level. When we looked in Leeds, Robbie Foy is the professor of primary care there, we looked at opioid prescribing in Leeds. There's a big practice level factor in there that accounts for a lot of it. There's something about you've got to get together and it's got to be a case discussion. But that's quite difficult to, even if you've only got 40 people, you've got to have 40 cases. Well, this is how we're going to manage this. But if you don't do it, nobody else can. Because it has to be everybody agreed about things like stopping opioids. The second thing is that a very, very similar idea, what you're going to do about not referring for investigation and how people handle the anxiety provoked by and sometimes active confrontation provoked by that. And the third thing that I think GPs can do, and this is something, now we're moving into this, services don't work very well like this. This business about what the liaison psychiatry meant when all this was set up many years ago was a relationship between a psychiatrist and a physician. A healthy liaison, it wasn't nothing dodgy going on here. But the idea you could just talk to somebody, you didn't have to refer everybody, you could discuss cases. And that's not a big part of how most services work now. They're very much, the GP's over here trying to plough through it all, and every so often needs to refer somebody on. And the idea that you might have a regular meeting where you sit down to discuss difficult cases is a challenge. So here's the last bit of what I want to say. I think the solution doesn't reside in pathways, it doesn't reside in pyramids, it resides in networks. And this is a wonderful network diagram from the National Art Gallery in Sydney, Australia. So it's Indigenous Australian art, and it's both a geographical map and a history and a social network that I can't explain to you now because I'm getting 5-minute sign waved at me. So I'll move on and say what I mean by that. Here are all the bits of services in a typical, so I'm talking now about how we can, so I'm stood back and I'm thinking, okay, we want to integrate physical and mental health care in a way that makes it possible to manage for the best this severe group of people, all the other people in the frame as well. I mentioned with Joe earlier on, one of the other interested people with mild learning disabilities and type 2 diabetes who need some help with self-management. They've got to be managed as well as this group, as well as the people with a chronic psychotic disorder who've got very high risk of ischemic heart disease, say. And so we've got to think about how all these, so some of that's in the mental health services, some of it's in the acute hospital where I work, some of it's in primary care. I love this. If you put primary care into Google Images, this is the picture you get. If you look inside a GP's head, this is the picture you get. And they all do different things in the acute hospital, whereas the hospital-based liaison, obviously lots and lots of the most severe physical illness, the most severe medically unexplained symptoms, other things in which I'm interested that we're not talking about here, self-harm particularly. If you go to mental health services, you get this problem of people with so-called severe mental illness, as if what we're talking about is not severe, and people with comorbidity, physical illness and learning disability. The life expectancy of a woman with learning disability in this country is 20 years less than the life expectancy of somebody in the general population. And people are nodding there. You know that, most people don't know that, and most people aren't as embarrassed about it as they should be. What GPs are doing, that's what we're talking about, and what IAPT's going to do. So, can we work out how we network all this lot together? Nearly finished. There are two ways of thinking about care networks that I think are really interesting. Here's one way. It comes from a literature on what's called social capital. That social capital, think of it like capital in a bank. It's something you want to draw on. And it resides in clusters or clumps or groups. So here we might be thinking about the sort of social capital that's expertise, knowledge and expertise, or access to resources. So sometimes it's quite close to actual capital. And the strength, therefore, of the network resides in the strength of the clusters, what used to be called cliques, for not a very difficult to see reason, because the tighter the boundary, the thicker the boundary round here, the more it looks like a clique, unless it looks like just a natural cluster. Here's the other way of thinking about social networks. There are two clusters here, But the important thing is the link between them. And what was called in this extremely widely cited paper, weak ties, the strength of weak ties. You don't have to integrate them, they don't have to be part of one system, but they have to be in touch with each other. The strength of weak ties paper has been cited more than everything I've published in my entire career. And it's a great, great idea. And it's one of the reasons that people say, for example, that the middle class, and mention another dirty word, which is social class, middle classes do much, much better out of healthcare than working class people do, because they have good, weak ties. They know somebody who knows somebody who can do something. And most people aren't like that. They only know the people in their immediate social network. So it's that connectedness, but it doesn't need to be my twin brother's the Prime Minister or anything. It just be I know somebody who knows somebody. So I think then if you want to plan to provide things, you can have these strong clusters where there's expertise and you develop transferable learning. And in my neck of the woods, I think every hospital, every acute hospital, because of how expensive it is, must have a liaison service. I personally think everybody in that hospital ought to be in the same bit of the service, so I can't be doing with the fact that psychiatry and clinical psychology are in separate bits of the service in the same or in dealing with the same sort of problem, but there are I suppose they're too closely related as disciplines for it not to be sort of squabbly. So that's one thing that I think is really important. What would weak ties look like? I think it would look like the sort of service that you would build up to manage the ischemic heart disease risk in people with chronic psychosis, for example. You wouldn't try and integrate, because most of that ischemic heart risk can be managed in general practice, and you wouldn't say, all we've got to do is merge mental health services and general practice, but we've got to have links that make it work. And the same, I think, for most learning disability and physical illness, links that make it work, that don't need to be very, very strong links. And then mixed economy. I'm hesitating here, because this is the bit that I think is flakiest, that we don't know how to do. And it's linking together the high volume stuff that IAPT is doing, or plans to do, with the primary care-based stuff. And I have to say, Brendan, I think the chances, we've got to think of a different way of going about this primary care thing. I think the chances of scaling up the sort of project that you were talking about earlier to be a national model that is, as well as IAPT and mental health services, acute specialist mental health services, is just not a runner. So we've got to think of a new way of doing that, that's somehow a hybrid between developing the expertise, or maybe using the expertise that resides in hospital-based services with linking into primary care more effectively. That's me done, I think. Who knows where that is? It's in Sowerby Bridge, or just up the road. So I'm so famous I have health centres named for me. And I am so important that there is now pedestrian access to me, should you so wish it. Avoiding steps. Who remembers steps? They were a dreadful band, I thought. So that's me finished. Thank you.